participants. I welcome you all to another live session at the Rehabilitation Science Group YouTube channel. Today we are with our esteemed speaker, Dr. Manish Samnani. Manish Samnani is a Master of Occupational Therapy with specialization in pediatrics and is also a PhD scholar. Currently, he is the clinical director at Soch Gurugram and is also the president of the Haryana chapter of the Occupational Therapy Association in India. He is managing a multidisciplinary team of specialized therapists. He is also on the advisory board of various organizations and institutes, both nationally and internationally, and is privileged to be a part of many researches along with international universities. He is certified in sensory integration therapy and neurodevelopmental therapy. His core interest areas include occupational therapy and its role in autism, behavior, and sensory integration disorders. Today, he will be presenting a topic understanding sensory processing difficulties in traumatic brain injuries. With your consent, Dr. Manish, we may like to proceed with the lecture.
Sure. Thank you so much, Dr. Harpreet. Uh, Thank you for inviting me for this program and have thought about me as somebody who could contribute. So, like you said, today's topic is about sensory processing in traumatic brain injury. Uh, we all know that the traumatic brain injury is usually from a blow to the head, such as in car accidents, sporting field blows, falls, and what it can lead to. It usually involves a severe and lifelong debilitating deficits in cognitive and sensory motor functions. Now, this sensory motor difficulties is something that we all usually talk about. We talk about how we can rehabilitate these kind of difficulties when it comes to the neuromotor aspect, the muscle tone, the coordination, the physical aspects of the traumatic brain injury. But studies have shown that along with sensory motor difficulties, the cognitive difficulties and sensory processing difficulties are also a usual long-term effect of the traumatic brain injury. There have been several studies on animal models where researchers have induced brain injury to the animals to study what could be the effects of such an injury on their brains, on the sensory cortex, on things that are more relating to sensory processing rather than only just the physical. So today, that is why we thought that we'll talk about not just about uh, the brain or the physical dysfunction part, but we'll also talk about the other aspects which are usually not the part of our discussion and rehabilitation. So let's start with now. Usually you would see that sensory processing and sensory modulation are the two common terms being used in the language, in the lingo that we read about in the literature or otherwise. The third major area being praxis, but I understand that praxis is something that we already kind of know about. We already connected to the physical aspect of the rehabilitation already. So let's talk about more about the sensory processing and the modulation aspect of it. The sensory processing in simple is actually about handling of the sensory information by our own neural system. What it means is there is a huge sensory input that is always present all around us. There is a huge amount of sensation available in the environment that is constantly being inflowed into our brain. Our brain is actually intaking a lot of sensory information. In fact, it is sometimes said that the primary function of the brain is to actually receive the information or receive the sensory information and process that sensory information. So along with that, the sensory processing is about how does the brain handle such a huge amount of sensory information that it is subjected to. The other related term is called the sensory modulation, which is about using the sensory input which is available in the environment, which flows into our brains, and to use this sensory modulation in such a way to change our level of arousal. We'll talk about this level of arousal, the other things in the form of a model as well. However, we should all know that this arousal, we say, or you could say a neurological arousal, is very vital to brain injured people. And hence, we should be studying about it a little more. Now, in 1997, an occupational therapist, Winnie Dunn, gave a model to understand what we just talked about, what we talked about sensory processing, about sensory modulation. And she gave a model which does not just applies on children, but it applies on children as well as any other age group people. And it also just does not apply on people or children who have a diagnosis, but it actually applies on all of us. What this four quadrant model of sensory processing talks about is basically this model has very simple two constructs. One is a neurological threshold, and the other is a behavioral response. What it says is that every human being has a unique neurological threshold of its own. This neurological threshold is actually different across the sensory systems. So if you have a lower neurological threshold for, say, tactile or touch sensory system, you might have a different sensory threshold for your vestibular or proprioceptive sensory systems. Every sensory system has a unique threshold, which could be low or high. Now, we'll talk about how the low neurological threshold affects us and how high the neurological threshold affects us. But another important aspect or construct of this sensory processing model is about the behavioral response that the person will give in response to these neurological thresholds, meaning thereby that the neurological thresholds might lead you to taking some active action. It might lead you to also being passive to it. So you have every brain has two choices. They can either have a little passive response, as if not doing much about it, as if not minding it. That would be passive. The other neurological or other behavioral response to this neurological threshold would be an active behavioral response, in which the person will actually act out. He will do something in order to counteract, in order to do something to balance this neurological threshold that he already has or is subjected to either naturally or is subjected to that kind of a neurological threshold because of the brain injury that has happened. So overall, this model then is talking about how sensory processing affects a person's behavior, and it also tries to make us understand that in a quadrant, where can a person be out of the four choices? Where can a person be, and how you can actually predict the behavior or maybe understand the behavior that is already showing due to brain injury is because of the underlying neurological threshold. Here is the Dunn's sensory model. The Dunn's sensory model, as you can see on the left half, is about the neurological threshold continuum. And on the right side, you see a behavior continuum. On the left side, on the neurological threshold continuum, you see that there could be low threshold, and you could see that there is also a high threshold. When someone has a neurological low threshold for a sensation, for a sensory stimulus, what is going to happen is that he would be sensitized towards it. If he has a low threshold, he gets sensitized to it very soon. Or you could say in other ways that every human being has a certain threshold for activating your brain. Now, if you have a low threshold, it would mean that your activation of the brain happens with a minimal amount of sensory stimulus. Whereas on the other side, if you have a high threshold and if you are receiving sensory stimulus, then you would need a lot of sensory stimulus to actually activate your brain. So that would be high or high threshold. Or you could understand, if you know those terms, you understand that a low threshold is like sensitization and a high threshold is more like habituation of the neurological inputs. Now, the second important aspect that Dunn talked about, and that talks about the model of sensory processing, is that even if you have these neurological thresholds, your brain can have four different kind of options or four different kind of quadrants in terms of the behavioral response that you would give to these neurological thresholds. In fact, you could again understand it simply by saying that either you are being a little active or you are applying self-regulatory activities to yourself, or you are a little passive towards it. Depending on whether you are active or passive, you can be either a sensation seeking, you can be sensory avoiding, that you will do something actively to either seek more sensation or you might avoid some sensation. And as you can see in the whole picture, if you see as a whole, the sensation seeking that you see here would happen more when you have a high threshold. Meaning thereby that when you have a high threshold, your brain will actually look out for more sensation. It will try to act out. It will try to behave in such a way that the person will seem to have a lot of behavior problems. The brain does not understand the word problems. It just does those behaviors because it is trying to seek some sensation. On the other side, if you are low on your threshold, you might be on the sensory avoiding side, or you might do something actively to avoid the sensation. But remember that this does not mean that if you are avoiding a sensation, you will actually be very passive. You will be sitting at one place. You will be shutting yourself down. Sensory avoiding is different than low registration, because in sensory avoiding, what can happen, and the closest and the clear example out of research is that when people are tactilely defensive, is that when they have a low threshold for tactile sensation, they get activated by tactile sensation, they actually move around a lot. They are trying to avoid tactile sensation by moving around, which means that if you have avoidance for tactile, you might actually be moving much more than a usual person. Again, meaning thereby that just looking at the person or just looking at the behavior does not tell you whether he is into high threshold kind of a person or a low threshold kind of a person. Let me explain to this kind of a chaos or a confusion in a uh, different picture. As you can see, a low registration kind of a person is someone who needs additional input to respond to stimuli, but takes a passive approach. He needs additional input because he's at a high threshold. So if you see the upper half, if you divide this picture along the self-regulation continuum that you see in the middle, the upper half is the high threshold people and the lower half is the low threshold people. The high threshold people might need additional input, but they are using a passive approach, and they are typically trying to say to themselves, I don't seem to notice when my face or hands are dirty. These are the people who have low registration. They have low registration because their threshold to the stimulus is high, and they are also very passive to doing something about it. Their brains are not doing much about it. Whereas on the other side, look at the other side of high threshold. Look at the other side of seeking. They need additional input to respond to stimulus and actively seek stimuli. I like to attend events with a lot of music. This would be an example of a person who seeks sensation. He is not somebody who is passively sitting about it. He's actually going along or playing along the sensory threshold. Because he has high threshold for sensation, he's actually looking forward to giving his brain more sensation. That's what a human brain is wired to do. If you are hungry, you are looking out for food. Similarly, when you have an hunger for sensation, because you have high appetite for sensation, because you have high threshold for sensation, you are supposed to look out for sensation so that there is a balance that is achieved. That is the balance that we are talking about as self-regulation. So these are the people who are looking for sensation. I like to attend events with a lot of music. I like to go on a car ride or a bike ride with good amount of speed. I like to go on joy rides. I like to go on trekking. I like to go for tourism. I like to go on long road drives. These are the people who are looking for sensation, and you would identify such people in your friends, in your family, probably you yourself. You could identify yourself as somebody who is here. If you are somebody who is here, you know that this is happening because you are behaving in line, in alignment with what your neurological, what your individualized neurological threshold is. And your individualized neurological threshold is actually high. Now, look at the other side of the people who were saying, I don't seem to notice. Now, these are the people who are very easygoing. They're very contented. They don't mind much, many things. They are, you could say, he doesn't mind or he doesn't feel much. He doesn't feel much because he has high threshold, and he's not in a way to, he's not trying to uh, really seek out as his brain is trying to tell him to do. Now look at the lower half. These are people who are on the low threshold side. Now, again, on the low threshold side, you can divide the low threshold side into two kinds. One who would be passive about it, and one who would be the actively doing something about it. Let's look at the ones who are passive. Responds readily to low threshold stimulus, but does not actively avoid stimulus. I startle easily at unexpected or loud noises. Now, these people are those people who have low threshold, and we know that they have low threshold only when a high amount of or high intensity stimulus is given to them. They are not people who are actively engaging in ensuring that the sensation should not reach them. They're not trying to shield themselves. They're not trying to do something. They're not trying to create a den for themselves so that they can just go inside and be there. They are definitely people who have low threshold, because whenever a sensory stimulus is of high threshold, they react to it negatively. But if that high intensity stimulus is not there, then they're pretty okay. And hence, these are the individuals which will show some response to the sensory stimulus. In fact, they will show abnormal response to sensation, which we might call as sensitivities. And we might talk about specific examples of what happens in traumatic brain injury. But these are people who have sensitivities, and they are not really actively trying to shield themselves out of those sensitivities. However, they continue to be sensitive. They are the people who might say, I do not, if somebody else touches them unexpectedly, they hate it. If somebody is trying to help them physically, they might hate it. If you as a therapist are trying to physically facilitate something in the person's body, and the person doesn't like it, he gets very upset about it, very irritated about it. Probably you are looking at somebody who has low threshold and who is who is sensitive to tactile input. If you have somebody whom, when you put him onto a balance board, if you put him on activities that require a little vestibular input, they are very fearful about it. They avoid it. They probably scream or make some sound when you put them on it. And hence, you know that it is very difficult for you to kind of train them for balance or other activities. These are the people who are sensitive to vestibular. And hence they are on the sensitive side. They are on the low threshold side for either vestibular or for tactile. On the other side, the low threshold people can actually be active people because they are actively trying to avoid the sensation. They're trying to ensure, make some changes, take a physical action to make sure that the sensation never reaches them. It's a defense mechanism. If the sensation reaches them, they will be troubled. They will be they will be uncomfortable. So what they do is they try to ensure that the sensation should never come to them. They are the people who will not wait for you to touch them and then respond negatively. In fact, in the anticipation of you touching them, they will push you away. They will avoid you. They will move out. They will move away from you. And if you are somebody who's trying to do something on the vestibular side and they have pretty low threshold about it, they will not even get onto such an equipment. They will not want to get onto the balance board. They will not get onto any kind of an equipment or a gym ball probably, or something that you are using in rehabilitation that has a vestibular input. They will ensure, they will make sure, they will never even agree to such a program. They will have tantrums if you do such a program with them. They will look like as if they are being stubborn. So look how the behavior changes just because you are trying to avoid a sensation. Let me show you another picture that will help you assimilate what we just talked about in this 4-quadrant model. Let me just help you there because it might take some time to kind of assimilate and process this information. And take a little while, take 5 seconds to look at the next picture and read what is there already. It's again the same 4 quadrants. It's again the same content, but let's see what do the boxes talk about, and you can read about it. Take a little 30 seconds to read it. As you can see in the picture, there are again 4 quadrants. On the left half, you see the neurological threshold continuum, which if low, on the lower end you can see, which if low can be talked about as super sensitivity. These people are super sensitive. And when we say super sensitive, we are not just talking about one particular sensation or only tactile or vestibular. We're talking about any kind of a sensation. It can be auditory, it can be sound, it can be taste, it can be smell, it can be any sensory system that we are all aware of, the 5 sensory systems that we are aware of. Along with them are the 2 sensory systems of vestibular and proprioceptive that we usually talk about. I assume that we all are aware about the sensory systems, and that is why we are not even including those details here. So when you are super sensitive, either you are super sensitive because you have a low threshold, you are over inhibitory if you have a high threshold. You are so not affected by sensation, so not cautious about sensation. If you have a high threshold, you might seek sensation so much so that it is actually not safe for you. You might take sensation so much so that it makes you socially odd. You might seek some sensation which is so much repetitive in nature. So it's what Winnie Dunn talks about is it's not just about understanding the normal human nature, normal human behavior, or normal human threshold, neurological thresholds and behavioral responses. But what she gives us as a model is to understand what might be happening with those who have sustained an injury, and that injury is leading to altered thresholds, and that altered thresholds are then leading to altered behavioral responses. Let's look at that again. If you are someone who has a high threshold, you might have a low registration, and you might be sensation seeking. Now, how is that? Now, as you can see on top, if you are responding in accordance with the sensory thresholds, with the neurological threshold, if you are responding in accordance with it, you will be having low registration because it has become your nature. Since you have a high threshold, you don't mind. Somebody steps on your feet in a bus, you might really severely respond to it, or you might be just be okay with it. You don't mind it, you don't care for it. That would be a low registration. The problem with low registration is that if you have too low registration, too low because of a head injury, you might miss sensory stimulus, you might get slow to respond, or you might not notice sensation at all. What that means is you might become so passive, you might become so low in your neurological arousal that you are actually not participating actively in the rehabilitation. You might be somebody who might be called as a person with low motivation. And guess how many times you see people having traumatic brain injury with low motivation towards rehabilitation? You can have a better answer for it, that whether you see people who are just not motivated, who are just not there on board with you when you are asking them to be participating in the rehabilitation program. Now remember that this model is talking about that the reason for that low motivation could be, and I'm not saying this is the only reason, because there could be other reasons as well. There could be psychological reasons that we usually attribute it to. There could be person's nature that we attribute it to, which the science may not really agree. There could be various other things that you might say the person is really depressed or something. But think about it, the person or the child with traumatic brain injuries brain might be low registration as a neurological threshold, which might be leading to that. The second option that you can have for high threshold is that your brain will actually try to counteract the threshold. Your brain will say, no, this is not what I'm okay with. I'm going to actually do something about it. And the brain starts responding to counteract the threshold by seeking some sensation. This kind of a person enjoys sensory stimulus, creates sensation in the environment. He's the one who creates the sensation. For example, if you have seen a client, a child, an adult who is himself trying to tap on the table repeatedly, himself trying to create sounds repeatedly, creating useless kind of sounds from the mouth, banging objects just to create sounds. I'm just giving an example of one sensory stimulus only, just to give you some kind of a clarity and simplification. However, this can again happen in any sensory system, that you might seek sensation. You might do something that is risk taking. You might do something that is not safe. You might do something that is socially very odd. But remember that this may not be just a behavior. This might actually be the person's counteracting the threshold for sensation. The second option could be sensitivity to stimulus. If you have low threshold, you can be sensitive to stimulus. In this case, you would be very distracted. You will have low attention span. You will have discomfort with sensation. And guess again, how many times do you see people with traumatic brain injury with low attention span? This could be that if you are so sensitive to sensation, you are avoiding it so much that you might be sensitive and avoiding and getting distracted. You could also be sensation avoiding. You will limit the exposure to sensory stimulus. You'll do something to ensure that nobody comes near to you. If you are a tactilely sensitive person, if you have a low threshold, you will push other people. You might hit other people just to avoid them to come close to you. So that's how the model talks about the behaviors. Now, in children, because sensory processing was initially and a lot of times now is regarded as a model that has a developmental perspective. In children who are counteracting their neurological thresholds, maybe described as seeking or avoiding, that we just said, these children may constantly touch objects, be constantly on the move, because they are trying to obtain sensory information from the environment. On the other side, those who have low threshold can be described as sensory avoiding or trying to avoid sensory stimulation. They might stick to predictable routines. They might do repetitive activities and avoid activities that require a lot of touching or moving, because the novelty of a sensation, the novelty of the activity actually is just the opposite of avoiding the sensation, and that is why they avoid the activities. Like we just said, the sensory processing difficulties in one of the quadrants can make you very sensitive. Because you have low threshold, it can make you sensitive. Research has shown that enhanced sensitivity is seen in visual, auditory, and touch processing in pediatric TBI patients for up to a year after the injury as well. Whereas auditory and visual deficits have been seen in adults with traumatic brain injury. So those kind of sensitivities have been reported already. These kind of symptoms in traumatic brain injury are seen more commonly when the traumatic brain injury is very subtle. So remember that there is a double whammy here, because on one side, these sensory processing disorders are not something that you see as an evident motor dysfunction, or as evident something that is not attributed to something else, but only says it is actually attributed to so many other things, person's nature, person's personality, person's psychological issues as well, that you might actually miss them out, not just because of various factors contributing to those sensory issues, but actually you can also miss them out because typically these issues are seen more when you haven't had injury, but you are not having injury which is detectable or visualizable on an MRI or CT scan. Now, if you have sensory processing difficulty in traumatic brain injury, you could have the following behaviors. You could have increased frustration. You could be the client or patient is angry, has aggressiveness, and I'm sure you all would have already seen a lot of people with traumatic brain injury who are very aggressive. They're also very language a lot of times. Impulsivity. They have difficulties in self-control. They have faulty judgment. They don't know what is right and what is wrong. They might be abusing their spouses and children as well. They might be talking very in an aberrant way to their elders as well. So their judgment gets affected. Decreased ability to initiate conversation happens in TBI. You could also see repetitive behaviors, also called as perseveration. You could have less social skills. You could have changes in your sexual behaviors. You could have very poor self-awareness due to traumatic brain injury. But it might be attributable to sensory processing. Sensory processing can also have problems, and that can be shown in emotional difficulties like depression, anxiety, mood swings, and changes in self-esteem. I want to talk about repetitive behaviors because you see these behaviors a lot of times, which are also physical behaviors, physical in nature, that the person gets stuck on one idea or one behavior and tries to repeat it again and again. I have seen a traumatic brain injury person who would put his hands inside his pants again and again. And when asked to stop, or when asked to a reason why he's doing it, he says, I don't have a control on my hand. It just goes again and again. to my private part. So you see that these traumatic brain injury people actually lose a sense of control because they have a sense of perseveration, they have a sense of repetitive behaviors. Remember that especially repetitive behaviors of perseveration are something that you see due to sensory processing as well on one side, but you also see these happening due to the problems of the frontal lobe injuries. What happens when you have repetitive behaviors? The person starts writing the same letters or words again and again. The person repeats physical movements again and again. The person gets stuck on one topic or theme. When can I drive? When can I drive? When can I drive? When can I go home? When can I go home? I need a cigarette. So, all kinds of repetitive movements can happen. The frontal lobe dysfunctions that we talked about that leads to perseveration, that leads to repetitive physical actions are actually classified under what we call as the executive functions. One important executive function, and this is not all of them, but one that was very relevant, is about mental flexibility. That the person with traumatic brain injury goes into this perseveration, stereotypical behavior, and goes into these problems of motor repetition, because not just because of sensory processing, but also because of the issues of mental flexibility due to the executive function loss, due to most commonly the frontal lobe dysfunction or frontal lobe injury in the traumatic brain injury. But remember that the sensory and executive functions come together. It is said that the executive functions of anybody's brain are actually based on their normal processing of the sensory information. So in that way, then, if I want to improve executive functions, if I want to improve perseveration, if I want to improve the repetitive behaviors, I will have to still talk about or still understand and assess the sensory issues, the sensory processing issues primarily, because if you miss out sensory processing difficulties, you will see much more executive functions difficulties than usually. So that is how you could have a person with head injury with with either difficulties with sensitivities, you could have difficulties with behaviors, you could have difficulties with social, emotional, and psychological functions, and you could also have certain things which are common to executive functions, especially to the perseveration or mental flexibility kind of issues due to the frontal lobe injuries. So these are the three basic ways how sensory processing issues can uh, can express itself in traumatic brain injury. There are a lot of studies going on not just animal models, but now also on the adults to assess the long-term effects of sensory processing issues on adults and people who have traumatic brain injury. But it seems logical that they do have a huge impact due to this dysfunction, and a sensory processing model for assessment and for treatment can complement the rehabilitation, the usual rehabilitation approaches that whatever any clinician is using. It can really complement those to and can have a better outcome of function, of ADL, of behavior, of social emotional, if you join the sensory processing framework to the overall rehabilitation. I will I'll stop here and take up, if there are any questions, then we can take them up.
Uh, Thank you, Manish. Uh, I think you have raised a very important point about the therapist's mindset on the focus towards the neuromuscular problems. And many times the sensory problems or dysfunctions are missed. And it really affects the outcome of rehabilitation, overall rehabilitation that we achieve within the patient. So, Manish, I wanted to ask you that do individuals have their uh, signature or characteristic sensory uh, threshold or active or passive type of response to sensations throughout their life, or it is possible for them to change?
Yes, that's a good question, actually. So, like I talked about Winnie Dunn's model, she actually says that every person has an individualized threshold and behavior kind of a response that is not just describing overall sense of the person. It's actually depends on sensory system to system, differs. One second, it can also differ within the same person. It can differ due to various reasons also. For example, if you are in an anxiety state, your sensitivities towards sensation can actually get heightened, right? So imagine that you are very anxious because of something. Let's take an example. Suppose you are going into a dark jungle, right? Now you are in an environment that heightens your state of arousal or neurological arousal.
Right.
Now even if you are somebody who was otherwise on the high threshold kind of a person, you are actually in that state into a low threshold kind of a person, because
Okay.
the environment has subjected you to those kind of changes. So with, and also the other thing is about your stage. Like suppose if you are a person who was a very usual fluctuating between high and low depending on the day-to-day life and situations, but then if somebody has a traumatic brain injury or any other dysfunction of the brain, can vastly change from what he was. So we do have uh, a phasic kind of a threshold as well. You do have a tonic, so to describe, just to put it into a
Right.
perspective.
Right.
You do have a kind of a tonic, but then it goes more into the personality side rather than into the
Correct.
neurology side. But you do have a phasic sensory threshold to every sensation, and you do have a basic as well. So if I'm somebody who does not like closed necks, I don't like closed necks for my whole life actually. I just don't like it. I'm somebody who doesn't like it because it kind of touches my neck so much that I don't like it, right? And
Okay.
there are so many people in our we know of them, like we say introvert people. Now what we are saying in introvert people is actually they're trying to ensure that they avoid sensation out of the social stimulus,
Correct.
and this is how they are. I mean, if the way you are is does not affect your function, then it's you should be happy, and everybody should be happy about it, right?
Right.
Because it just translates into personality. However, the model gives us more about understanding about specific situations that you are subjected to, extremes of situation or injury.
Right. And there was one more query about uh, how do we identify or differentiate the sensory processing difficulties from isolated behavioral issues? So, can I tell that is this a behavioral issue and not a sensory issue, and how to do that clinically?
Sure. Yes. 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 In fact, I raised another point where it becomes very confusing is about the executive functions as well. You could have a behavior. See, basically, as clinicians, as therapists, as people who who do not believe only on the conditioning kind of a perspective, we should not believe on the conditioning. So when you talk about behavior,
Right.
we somehow go into our Pavlovian kind of a thinking. The dog sees a bell and starts watering because he was
Yes.
conditioned for the bell and the food and the watering of the mouth. Now usually behavior is seen as a conditioning perspective, as if
Okay.
whenever this happens, whenever he is not given this object, he goes into a tantrum, suppose, for example.
Correct.
Now sensory actually is way different, or actually very opposite of this conditioning kind of a perspective. It says that if you want to identify sensory issues, you should look at the behavior, observe the behaviors, but don't go by the behavior. So if you see somebody putting their hands in the pants, suppose, for example, in traumatic brain injury, he's repeatedly trying to take his pants inside, hands inside.
Yes.
One of the ways that you should be doing is to first apply the sensory lens to it. Ignore for some time the fact that what's the exact behavior here. Forget about the exact behavior of what the person is doing. Think about how is he sensitive to low or high, in the tactile, in the proprioceptive, in the vestibular by tests of tactile, proprioceptive, vestibular. You need to test him. You need to collect data. You can generate some hypothesis to say, okay, I hypothesize that this person is doing it because of tactile, low threshold, leading to high amount of sensory seeking. Now I hypothesize it. I will reject my hypothesis once I do the testing of the tactile sensory system in this particular person. I will give him sensory stimulus. Unless and until I give him sensory stimulus, I cannot conclude, or I cannot reject or accept an hypothesis of a sensory stimulus or response to sensory stimulus till I have actually given a sensory stimulus. Right? So
Right.
I cannot go by the behavior just because I have not even given the sensory stimulus. One. Second, sensory will always show you a pattern. So for example, if you are somebody who is looking to touch your collar again and again, I
Yes.
need to see what else in your tactile system has got affected. Has
Okay.
your ability to discriminate, as if stereognosis, got affected? Has your seeking of sensation, not just here, but it is also maybe when food is given to you, you start touching the food. Maybe a tablecloth that is in front of you, you start touching it. I will have to collect data from the parent, from the family, and by my own observations, which can be, by the way, formal and informal as well. Because you have sensory test. The sensory profile test of Winnie Dunn is applicable on adults as well. You can actually apply a questionnaire, which is called as a sensory profile, to
Okay.
generate data on how is his sensory system at the moment. Is it low registration? Is it sensory seeking? Is it sensory avoiding? That kind of a quadrant is actually created depending on a score on the questionnaire.
Yes.
But remember that a clinician should never rely completely on a caregiver or self-reported questionnaire only, which the Winnie Dunn sensory profile is. The sensory
Okay.
profile is actually a questionnaire which is either self-reported if the client is able to do it, or it is reported, a questionnaire reported by the caregiver. Now,
Yes.
it if you know, the questionnaires will always have those two limitations. Either you can actually undermine what is already there. The person is actually touching his ear again and again, but this person, the caregiver, actually undermines it and scores it at 0.
Right.
On the other side, even if once you touch someone a little oddly by chance, and he says, if the questionnaire says that does he touch oddly, then you tick it as number 1, right?
Right.
That kind of a response does happen in questionnaire, and that is why I recommend that a clinician's judgment of tactile or other sensitivities or processing abilities should be tested in the clinic. And there are
Right.
ways of doing it. There are ways of testing the sensation in adults and in children. There are ways of you observing the various behaviors and correlating them. So if you see one behavior, you will also see certain other behaviors which all fall into the same one of the quadrants. And if that happens, you know for sure that it is not the behavior. It is
Yes.
actually going towards the sensory.
Right. Finally, Manish, there was one query that like such a benign behavior of repeatedly touching the collar or the ear may seem to be just a habitual thing. And so, when as a therapist do you decide to treat or to intervene in this?
Sure, sure. I would say it's a very valid and very, very good question. The underlying principle of treating sensory uh, is that if it creates a functional problem. When I say functional problem, it does not only mean a physical skill problem. Say, for example, even if a person puts 4 times in a day hands in pants, only 4 times or 2 times, maybe, let's say 2 times, but he does this in front of his mother or his children.
Right.
Don't you think it is enough to warrant a treatment, right?
Right.
Because
Right.
it is very disruptive. Yeah.
Right.
On
Right.
on 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 second side, if the motor behavior is repetitive, And that repetitiveness is so high that when you are doing a physical rehabilitation, it is actually interfering in your physical rehabilitation. The person is not able to participate in your prescribed physical activities, but is rather busy touching something else.
Correct.
And when you try to redirect him, it is difficult for you. It's actually taking a lot of effort for you to redirect him from his benign or so-called benign behaviors to those behaviors which are actually meaningful or which are actually productive in terms of rehabilitation or in his day-to-day life.
Right.
So
Right.
if they are competing, so it's not just about frequency then. That is why I gave
Correct.
you those two examples.
Correct.
You can have frequency, but you should also look at intensity.
Right.
Yeah,
Right.
and that can give you an idea.
So finally, thank you, Manish, for sharing this information. And I think this would change the perspective of rehabilitation for a lot of therapists listening to this lecture. Thank you for being with
Sure,
us today.
sure. Okay, thank you so much.